With you about a new imaging technique in acute kidney injury. We know that acute kidney injury is a common complication in critically ill patients. It is important to understand the pathophysiology of acute kidney injury to guide patient management. Renal microvascular alteration and hypoxia play a major role in the genesis of acute kidney injury. It may be possible to misunderstand renal microcirculatory alteration if relying only on assessment of the patient's macrovascular hemodynamic. So it is urgent to have a new imaging technique in both research and ultimately clinical settings. I want to talk about two techniques, renal contrast enhanced ultrasonography and multiparametric magnetic resonance imaging, because these two techniques appear to be the most promising imaging technique for exploring the pathophysiological mechanism involved in acute kidney injury. The first technique, the renal contrast enhanced ultrasonography. The principle is to inject microbubbles contrast agent, which are composed of bubbles of an injectable gases with phospholipid shells. Change in shape of microbubbles with ultrasound waves induce the generation of nonlinear signals with a very high echogenicity. This study is one of the first studies we use this technique in ICU. The study was performed by Schneider. It's during elective cardiac surgery, and they use the contrast enhanced ultrasonography with destruction replenishment sequences before the operation, on ICU arrival, and the day following the admission. And you can see that at the level of the cortex microcirculation, there is clearly from baseline to day after surgery a decrease in the perfusion of the cortical microcirculation. It is important to notice that 4 patients develop acute kidney injury in the post-operative period. We use the same technique in 20 ICU patients with septic shock and 10 control patients without sepsis. And we observe the contrast enhanced ultrasonography within the first 24 hours, D0, between 24 and 48 hours, D1, and after 72 hours, day 3. You can see that all these patients were resuscitated. We have restoration of mean arterial pressure, restoration of cardiac index. There is still an increase of lactate, but the patient appears to be optimized. All these patients had norepinephrine. And at the level of the kidney, this is on this slide the 3 different patients, just to show you how, despite the fact that macrovascular hemodynamic is similar, we can have very different behavior of the microcirculation at the kidney. At the bottom of this slide, in this patient, the microcirculation is normal, and here you have clearly a high alteration, a severe alteration of microcirculation. There is no flow at the cortex. And in this last patient, you have clearly a high flow. So looking at this, it's easy to understand that in this patient, resuscitation will be completely different. In this patient, in my point of view, we have not to give more fluid. And in this patient, maybe we have to give more fluid, maybe we have to increase the mean arterial pressure. We have to do something because the kidney has no perfusion. So what we observe, despite the fact that there is a high heterogeneity in terms of cortical microcirculation within patients, we observe that we have clearly septic shock in comparison to control group, clearly an alteration of the cortical microcirculation. And when we look at a patient who had an acute kidney injury at day 3, clearly this patient were the patient where there is a more severe alteration of cortical microcirculation. So clearly a link between the alteration of cortical microcirculation and the development of acute kidney injury. This study, it's also a pilot study where it's in a COVID patient and in septic patient, and there is a third group, it's healthy volunteers. You can see that they use contrast enhanced ultrasonography, and in these patients, you can see that just considering macrovascular hemodynamic, there is no difference between COVID patient and septic shock patient without any alteration of the left and the right cardiac function. At the level of the kidney, once again, renal microvascular flow was significantly reduced in patients with COVID in the absence of right and left heart dysfunction. It was true also in septic shock. So they confirm what we observe in septic patient with clearly an alteration of renal cortical perfusion. So a second technique is the multi-parametric renal magnetic resonance imaging. On this slide, you have some of the most commonly used quantitative measure that may be combined within a multi-parametric renal MRI protocol. So with this technique, we can have biophysical tissue properties that could be linked to fibrosis or inflammation or tissue edema. It's important because in our patient, we are afraid of tissue edema and renal edema, which could decrease the renal microcirculation. Also, it's possible to assess the total cortical and medullary perfusion, and it's also possible to have an idea of the tissue oxygenation. So this first study They use the phase contrast magnetic resonance imaging during a septic shock patient, and they measure the renal blood flow. They include 10 adult patients with septic acute kidney injury, and they compare to this patient to 11 normal volunteers. And you can see that clearly there is an alteration of renal blood flow. And when you look at the renal fraction, when you consider cardiac index, usually this renal fraction was around 20%, and here it's less than 10%. So clearly in this septic shock patient, an alteration of the renal blood flow. It could be also very interesting to identify potential non-invasive markers of renal pathophysiology in acute kidney injury, and to use this marker during recovery to maybe have a more smart approach concerning the sequela after acute kidney injury. So it's a pilot study. It's nine patients that they look at the time of acute kidney injury, and 7 had a follow-up at 3 months and 1 year. What they observe is, despite the fact that the creatinine and the clearance of creatinine return to normal after 3 months and 1 year, you can see that there is still an alteration of some parameters, and especially of the cortical perfusion, with ears in some patients still altered after 1 year. So I think that through this technique, it could be very interesting to use it to have a better follow-up of our patients. Another study where they look at it's in healthy volunteers. They look at continuous infusion of angiotensin II with incremental doses. And you can see that when they look at the renal oxygenation, there is a decrease in the renal plasma flow and a decrease in the oxygenation at the level of the cortex, and no change in the medulla. So it's a way to have a more clear idea of the effect of, for example, here, the vasopressors that we use. In conclusion, the availability of new technique capable of visualizing the kidney microcirculation and oxygenation is crucial. Renal contrast enhanced ultrasonography and multiparametric renal MRA are promising imaging technique, but more evidence is needed to show how they can first be more widely used in a research setting to test key hypotheses about the pathophysiology and recovery of acute kidney injury, and then ultimately be adopted in clinical practice to guide patient management.